Great, excellent. Welcome everyone, and good morning. This is the last training session of the summit, and do not be deceived by the number of people in the room. This will be recorded and will in the future be known as the absolute must-attend session. So this is where the rubber meets the road. Today's session, and now I have to pause because my iPad went out of screen, so I can pretend that I knew everything I was supposed to say. Anyways, this is where the rubber meets the road. We've heard a lot of stuff over the past several days about genomes and medical data and visualization and big data and the rest. But in this session, we're going to look at the health-related projects that the presenters today have worked on and overseen to improve the development of new data analysis and management tools. The presenters will be describing the challenges that they are looking to solve, how they overcame them, and what surprised them in the development. So this session will inform you of what is possible in healthcare with the new cloud, data techniques, and inspiring projects as well. Now, for those of you that are expecting me to follow the top-down alphabetical agenda, I've decided that was absolutely no fun. So I'm sure Zuckerberg always liked being the last one called up because he had everybody else's content to pull from and say, well, that's what my opinion is. So we're going to turn it a little bit around today. And our first speaker will actually be a joint presentation. First off, we're going to have Tyler White, who is the CEO of the Succeda Health Services. He's a member of the Succeda Nation and part of the Blackfoot Confederacy. He's the health director for the Succeda Nation for 12 years, and his leadership was recognized with the National First Nations Health Managers Award of Excellence in 2009, and a First Nation Service Award in 2008. White's achievements include establishment of one of the largest and most diverse First Nation health centers in Canada, successful accreditation with the Canadian Council on Health Services, the first memorandum of agreement between First Nations and Alberta Health Services, as well as the first data sharing agreement in Canada between a First Nation and provincial government. He's a champion of innovative information and communication techniques to improve health services. So Tyler, you're going to... Now Tyler is also going to be co-presenting with Sal Samanani. And Sal is a medical specialist in the public health and preventative medicine. He has over 10 years of public and private sector experience in the practice of clinical medicine, public health, and healthcare management and health informatics. Okaki Health, that's correct. Bukaki Health Intelligence is a social enterprise that aims to improve the impact of programs by assisting organizations with managing and using data in a critical, learn, and continuously improve in what they do. Gentlemen, welcome up. And they'll be presenting for 20 minutes, and you'll have a Q&A right after.
I don't know how we're supposed to compete with making money with the cloud. I wanted to head over to that topic. All right. Okay, so let's start with this.
Just before we start here, just want to again thank Siberia for inviting us out today. Certainly an honor and a pleasure to be here. Just want to get some introductions out of the way. Thank you, Peter, for that nice introduction. Just want to acknowledge some of my staff members that are here. Our IT guy, Larry, and our other technician, Garrett. Garrett, guys, wave. I'm not sure if we have any other First Nations out there. Anybody First Nation? If not, I want to welcome you to our territory, okay? Welcome. As Peter mentioned, I've been the health director and CEO for now going on almost 14 years. Prior to that, I was one of the tribe's self-government negotiators, so health really isn't my background, it's more management. And so I don't know how in the hell I wound up in health, but there's a story to be told there. And it's a real privilege to be working in this field and to be helping our people in this special way. So today we have a bit of a presentation to give you some of the background on in terms of our story and again how it all fits. And I'm not sure who has in here who has a good perspective or background on First Nation health, but it is quite diverse. And we're hopefully we'll do it justice today, myself and my brother, Dr. Sal, and give a bit of a presentation and backdrop in terms of what we've been doing and kind of where we're going from here. So Sal, you want to just explain your little cartoon?
So thanks, Tyler. 10 years we've been working together and he still has to remind me of the protocol. Okay, so the cartoon there shows a couple of physicians and they're performing something called the Thompson Test, which is a maneuver on the lower extremity that checks for a torn Achilles tendon. So clearly they've missed the point. So I wanted to start the chat or the presentation by really bringing you to the main point of what people like Tyler, myself, and many of our colleagues are trying to achieve, which is really to enable people who serve a public interest, and in this case we're going to talk specifically about First Nations health. It's to enable them to use data, to access and use data to do the best job that they can. Okay, that's really the point. So it may come as a surprise to some, it may not, but for the context we work in, there's a very high proportion of people who manage health, social, environmental, and other programs, where for them, using data to examine what they're doing, to look at how they're doing it, to assess the impact it's having on their target population, this is not even a part of their day-to-day activity. It's not even part of their capacity. It's not part of their discourse. Okay, so for them, their immediate and urgent needs are really not going to be addressed by figuring out new methods or platforms to analyze exabytes of unstructured data. For them, the point here is big data is really about the massive transformation, the potential transformation that can occur if we are just able to put the right skills and tools in their hand to start using data for their day-to-day work and their decision making. So, that's really the focus of today. So it's a little bit of a deviation from the big data discussion to date.
I'm going to just go back to that cartoon there. Sal and I were debating last night whether we should put a certain, you see the monitor there, the computer monitor? We were debating whether or not to put a certain government agency in that monitor, but we'll save that for another day and another slide. So back to the presentations. Thank you for sitting in the presentation. And again, I want to give you a bit of a backdrop in terms of our organization and kind of what we've done. You'll see here the Blackfoot Hospital, built 1926. We did have a hospital on our reserve. The present day Siksika Health and Wellness Center, it's about 35,000 square feet, probably one of the largest, if not the largest health center, First Nation health center in the country. Our vision and mission statements are similar to our leadership of Chief and Council. Location, again, we're about 100 kilometers east of Calgary, the second largest reserve in Canada, and a population nearing 7,000 people. Some of the partnerships we've done over the years, and again, I think, give you a bit of background on myself. I started as the health director in '99, early part of '99, and at the time it was quite unstable. I was about the 5th health director in a span of about 9 months. High turnover. We also had Health Canada and the band sort of operate under one building, 2 different sets of policies, different directions. So one of the first things I realized is that our system was quite dysfunctional. The systems that we had were very limited. The data that we had was non-existent. We wanted to do strategic plans, business plans, operational plans, community health plans. Really wasn't possible with the current setup that we had. So we definitely had to look outside and outside our normal scope of practice, and again, begin to develop partnerships. So you can see one of my favorite partnerships, I listed it right at the top. I have a MOU with Nike. So we are the only tribe in Canada to have an MOU with Nike. And this MOU looks at providing certain footwear to diabetics, youth programming. As you'll see in my later slide, I actually have an ulterior motive for bringing Nike, and I'm hoping for them to furnish our wellness wing of our expansion plans. So there's a reason why I've got Nike involved. And of course, Nike's a brand name. All the kids gravitate to that. So I'm like the vendor, the only vendor of Nike on the reserve. I can get any Nike products you want, wholesale price. So come and see me if you want Nike stuff. Anyways, again, we have a relationship with Alberta Health and Wellness, Alberta Health Services, Physicians Operating System Program. One of the things I recognized earlier on is that the way our doctors are set up, the fee-for-service, is completely the wrong model for, at least for us and most First Nations. There's a tendency for prescription drug abuse, and of course you can get the wrong individuals in there, and it can be a huge business. We had a doctor in there that would come in maybe for 2 hours and see 70 patients. Now there's just no way you can see 70 patients in 2 hours. It's ridiculous. So, earlier on I recognized, okay, we've got to change the system. And so looked at, again, working with some folks in Alberta and looking at working with the primary care network and looking at establishing an alternative relationship plan for our doctors. So we are the first in Alberta where all our doctors are on the ARP format. Again, it's not a fee-for-service, it's a straight salary, and they can spend much more, primary care with the clients. So that's the direction we took, and again, part of the reason why we're here. Again, the work we're doing with radiology consultants, Calgary Lab. We have a PACS machine, picture archiving communications system within our health center. Again, another first. We recently opened up ultrasound services at Siksika. Again, another first anywhere, to my knowledge, in Western Canada on a First Nation reserve. And there was, again, we have 100+ babies being born a year. Moms have limited means to travel, resources, so why not build it on the reserve? Of course, we did that. Worked closely with the Alberta government, and we did it. Again, there's an emphasis on which government we're working with, unfortunately. Again, we have other, working with universities, U of C, Monroe, U of L. Our last 3 doctors came from the U of C residency program. Our last batch of nurses came through the U of L nursing program. We just graduated 12 LPNs, so there's a real capacity building going on here, and it's great to see that happening where we have our nation members in those roles, and that's what we want to see. And of course, I can't forget, my brother here, Ogaki Health Intelligence, who's been with me with day one and has sort of started this crazy journey with me, and we're just, the hits keep on rolling. And last but not least, Siberia, of course. We've gone to them and partnered with them on a few projects, and it's been nothing short of spectacular, the work that's gone on with Siberia, so I'm very proud of that. Kind of where it all began, again, I gave you some backdrop in terms of our organization. We built a brand new facility. Of course, we were pushing the government on, okay, what are you going to do for, high speed, Wi-Fi, and there was no plan in place. So we went out at our own cost, worked with the Alberta government, and brought in the SuperNet. So we were the first health center again in Alberta to have SuperNet access. So again, another first. And this was really the catalyst for many of the activities that I mentioned and many more that we're doing right now. So just a simple little hole resulted in so many different things. I think I even had Larry dig in the hole at one point in time, and that's how involved we were in this project. Of course, we had Axia, do a profile on us, sort of the high-tech healthcare, and just talking about sort of all the ins and outs in terms of what we're doing as far as programming and services. Again, just some of the chronology, the data chronology at Siksika. We had our first hospital in 1890. We moved to the Siksika Medicine Lodge, which was a clinic with nurse practitioners. One of the things, again, recognized early on was this lack of data. And there was a lot of myths in our community in terms of people passing away, and it's a sensitive subject. And so, I went to Health Canada, and at the time Sal was, working, on the dark side there. And I went to him and I said, hey, can we put together some kind of a profile on our deaths of our nation members? And so we worked with a couple of epidemiologists for about 9 months, and we developed this death book analysis. So we went back 50 years in time and looked at every single death of our nation members. Looked at the information through whether it be provincial, federal data. We actually have a book, and there actually was a book in the clinic called the Death Book, and we went through that. And we had some elders involved in the process, and it had some very interesting, numbers when it came to it. Put a lot of myths, it addressed a lot of the myths in terms of decades, in terms of genders, in terms of age. It gave us certain profiles. When did we start seeing, diabetes, cancer, motor vehicles, et cetera, et cetera. So it gave us a really good profile and a backdrop. And that, to me, was one of the real things that made me sort of a believer in, again, looking at the data. So that resulted in many other things. It resulted in, again, this prescription drug abuse monitoring system, closely monitoring our doctors, pharmacists. We had the grand opening of our health center. Again, the SuperNet started. Worked with Calgary Health Region in developing a telehealth project. It was a 3-year project. Still doing telehealth services to this date. 2009, again, looking at the GIS system for home care, EMS, looking at disaster planning, whether it be electrical outages, floods, blizzards, other storms, you name it. We've experienced that at Siksika Nation. We moved out of the Medicine Lodge, and we turned that Medicine Lodge into a youth solvent abuse treatment center. So again, one of only 11 treatment centers in the country, the only one of its kind in Alberta. 2008, we talked about the PAC system. 2008, we also began establishing the electronic medical record. So again, the EMR. So we have a full electronic medical record system at the health center. Again, we're connected to Netcare. And I think Sal will talk about the CHIP program, which has been an amazing turnaround for our community health team. And I also have them speak to the historic information sharing agreement we recently signed with the province. So that's a bit of a data chronology for us. I think you'll see some success factors for improving data. You know, we're sort of one of the leaders in technology, info systems. It's assisted us in various planning models, awareness in the community, you know, increased visibility of indicators, trends, moving of population, and again, ability to implement plans and reports, such as their annual operational plan, peacetime emergency plan, etc. See some of our cadets at our annual health fair. We had an ambassador from Nike and N7 come out, Kenny Dobbs. And again, this is sort of this is the future. If you look right here, this is the present Siksika Health and Wellness Center in the pink. And so our plans are to expand beyond that. And again, look at a medical tourism component, look at public-private partnerships, and expand from a outpatient care to more inpatient, where we are looking at doing hip, knee, eye replacements, etc., doing various surgeries on there. So really, that's the vision. And again, building that capacity, you know, within the nation is amazing. Again, you know, that's been the work we've done within this area. I mean, I can't say enough good things. And having come across working with some excellent people, you know, I think it's been a huge factor in our success. And again, it's about saving people's lives. It's not about having the fanciest equipment with all the bells and whistles. It comes down to saving people's lives and the impact we're having on future generations. That's kind of why we're there. That's the motivation behind the work we do. So with that, I'm going to turn things over to Sal, and Sal will continue on.
So I'm proud of my brother, because that's his first 10-minute presentation ever. So we're going to give you one example. There's hundreds of examples of the issues around data, and we're going to pick one because it deals with one of the most basic services. It is the most effective and cost-effective and impactful public health intervention, immunization. If you look at the first thing you do when you go into a new area and you want to impact public health, it's water, sanitation, and immunization. Okay, so this issue, there's a long-standing, just accepted disparity. First Nations, it's a stat that's thrown around quite often in the public health world, and it's just almost as if it's accepted and unchangeable, but First Nations suffer from significantly higher rates of vaccine-preventable diseases, up to 6 to 8 times in some areas, yet they have significantly lower immunization rates. There's lots of problems with the data, but often in studies they'll quote around 60% or so. Records in the rest of the province prior to this initiative were on some form of electronic system, while on reserve we were still using multiple different sources of paper. The provincial registry, which is really supposed to be the repository of all immunizations for all children in Alberta, is a black hole when it comes to on-reserve shots. So there's no way to have a complete picture of what's going on. So the issue is that, in fact, while a lot of reasons are thrown around, the biggest, I believe, and many people believe, the biggest reason for this disparity is the way we manage and share records, immunization records. Okay, how does that impact the program? There's countless examples. When you don't have a complete record at the bedside, it leads to waste of time, it leads to missed shots or unnecessary shots. When you don't have a complete picture of your population, what you're doing, you can't measure how you're doing. That's provincially you can't measure, but even in a community you can't measure. So there's just, it's a huge problem. And you know, I'll put this slide up. I'm going to go a little bit quick for time, but we have, when we started this project, we collected anecdotes from the first 2 pilot communities, and every staff member in their public health or community health program gave their frustrations, their main frustrations with the program, and it all dealt with information. Okay, so this was launched. This is really Tyler's, I have to give him credit because his nurse in charge was new at the time, and the first thing she brought up after H1N1 is, what is going on here? We have to change the system. Approached us and said, you guys have been talking about this for 8 years. We knew her from 8 years ago before she went off to Capital Health, and you heard her complaining about this. And we've been working at it for 8 years, so how come, with her statement, you're still talking about this and nothing's done? So Tyler made the decision to fund the initiative himself and started off. And when he made that decision, a neighboring community in Morley also tagged in, jumped on, and so they really launched this. And the goals at that time, the vision was simple, that within 2 to 3 years, this is what we wanted to achieve. Okay, when I say First Nations should have systems in place to improve quality, simple things. You know, your Blockbuster's video will send you an email or call you for a reminder recall when it's overdue. Your mechanic calls you when your service is due. Reminder recalls, one of the most evidence-based interventions to raise coverage rates, is impractical in a First Nations context. It's impractical. They don't have the basics. Okay. So I borrowed this from Jeff Branch. I love this. I have to get his permission to use it, but I'll recognize it. The easy button. So what is the intervention? We're still refining the intervention, but basically, you know, describing why this hasn't happened is beyond the scope of this discussion. Describing why this very logical and needed and critical thing hasn't just happened till now is a whole other session in itself. But the challenge for us is we have to create the easy button. It has to be simple for people. So what do? First of all, we couldn't have done this without the infrastructure, without the internet going on there. So we've developed a cyber application which we think is the best in the business. It comes from a very deep knowledge of the program. Pfizer gave almost $200,000 in grants because they felt it was the same. We've got a number of funding partners. So that's at its core. We adopt all standards where they exist. If there's a standard, we adopt it. We have all the provincial standards incorporated. We handle all the privacy work, drafting privacy policies, procedures, training staff, writing the privacy impact assessment, going back and forth with the Office of the Privacy Commissioner. We do all implementation and training, missing public Alberta healthcare numbers. Something so simple. Well, you can't have a complete system where the unique identifier of every patient is missing in 30% of patients. So developing a process to fill in the missing PHNs, historical data entry back to 2005. If you don't know past immunizations, you can't determine future immunizations, et cetera, et cetera. The point being that, you know, we're trying to create the easy button. So when we walk in, the staff have to deal with the change, which is very stressful. The change to something they've been doing for over a decade, 20 years, some of them. And we do the rest. So this is the launch with a bunch of VIPs from Ottawa, from the province, various others, and a little bit of a timeline here. Here's some pictures from different communities. Oh, sorry, 2 more points. First system in the world to barcode scan at the point of care. This is in partnership with the Public Health Agency and Sanofi Pasteur, the first manufacturer to put 2D barcodes on their vials. So this year, all of the 2D barcoded flu vaccine was diverted, the supply in the country, to Alberta, because First Nations in Alberta are the only ones and the first ones scanning 2D barcoded flu vials at the point of care. So we're going to have 14,000 doses all scanned, well, in Alberta, and all the CHIP communities, which we'll talk about, will have this barcode scanning capacity. This is the historic data sharing agreement. As Tyler mentioned, you know, one of the big problems is kids are moving on and off reserve. They're getting their shots everywhere. The only way to get a complete picture is for information to flow between the provincial jurisdiction in Alberta. This is monumental, and it's the first in Canada. It's actually 2 data sharing agreements. This is the Chief of Siksika, the Deputy Minister of Health, and information has already changed hands. Now the issue is the province will have to modify their systems to work with CHIP in real time, but in the meantime we have some other stopgap measures. So a little bit of the timeline gives you a sense. This is September. So I talk about the building the foundation for other projects. So each of those little clover leaves is a CHIP site that starts, and we have associated projects that when we finish the CHIP privacy work it can move to net care, it can move to information sharing agreements, it can move to other system development. So green is when something sort of starts, red is when it's completed. So I'll just run through month by month: September, October, November, December, January, February. So that's what happens when you make the easy button, right? And this initiative is 100% community driven. Not a penny of federal funding has gone to any First Nation. So you know, that is actually the amazing part of the process. Now I'm going to show you some data, okay? This is called an on-time coverage rate graph. I'm going to end with this. How much time do you think we got? Okay, I'm going to end with this. It's a series of statistics, and I'm going to explain the graph to you. For each vaccine, you have multiple doses. The first dose sensitizes the kid. The second dose prevents death. Third dose prevents severe disease. And fourth dose prevents any illness. Okay, so you really need 4 shots to have complete coverage. You need to reach a target of what we call 95%. It's actually 92 to 96, depending on the condition, to have what we call community immunity, where in fact the individuals are not only protected, but when a vaccine-preventable disease enters a community, it prevents propagation. So that's why the provincial targets are around 95%. This is the age of the child, and this is the percentage of people who are immunized. So in an ideal world, if a shot is due, first dose of this is PDSL, it's a vaccine, it's 5 antigens or 5 diseases. And if the first dose is due at 2 months, in a perfect world, you're going to have all the kids immunized in 30 days. So what you see in a perfect world is at 2 months, you see the steep curve up to 95% and then flat. That's in a perfect world. Okay, so let's look at this vaccine. And this is after we had 500 babies in CHIP as a total cohort. So shot 1, shot 2, shot 3, shot 4. 50%, less than half of 2-year-old kids. So what happens when you introduce a vaccine-preventable disease in a population that's largely unimmunized? You get high rates of disease and death. Okay, so let's look at it now. Recently, as of August, we have a cohort of about 700 children in there now. Okay, so let's look at what's happening. This is for same doses. First dose. So first dose. Look at what's happening in 2012. And this includes people who just implemented last month, so it's the entire cohort of communities. First dose, second dose, third dose. You never see this in public health. You never see massive deviations in care. Okay, let's look at the early adopters who started 1 year ago, like 6 ago. Okay, same thing. Each line is a different year. It's a different annual cohort. I didn't explain that previously. So first dose, look at the 2012 cohort. Within 30 days, they hit 95%. Second dose, third dose. So, I mean, I have stopped trying to defend the project. So we'll leave it at that.
We have a couple minutes for questions from the audience. Thank you. Well, thank you, both of you. You know, Tyler, you brought a few things forward that I was thinking about all week around big data, and that is, big data is not the new oil because, first of all, it's a renewable resource. Well, what do we do with all the historical information? Where do we get that from? And one of the questions asked this week was, how long do we keep data? And golly gosh, you know, if our forefathers had kept their data, it would have been so much easier. Great, thank you very much. Oh, and by the way, let me talk to you about some late cross creamers. So next up, I know who you are. So next up we have Caroline McGregor presenting to us, and Caroline is the Canadian Research Chair in the Health Informatics at the University of Ontario's Institute of Technology. She has her PhD in Computer Sciences from the University of Technology Australia, and she's led pioneering research in big data, event stream, processing temporal data streams, data mining, business process modeling, patient journey modeling, and cloud computing. In the early 1990s, she led an implementation of the first executive information systems for one of the largest banks and largest retailers for Australia. These were two of the earliest business analytics software implementations in Australia. McGregor is now an international leading researcher in the area of critical care health informatics, and particularly the use of big data in neonatal health informatics, which she has specialized in for over 13 years. Join me with the camera.
Hi everyone, and first of all I wanted to acknowledge and thank the welcome to the land. As someone who comes from Australia, a very similar culture with the Aboriginal community in Australia, I'm very respectful and thank you for that welcome. So today I'm going to be speaking about the little people in our lives, some of which are very, very little. And the comment of the first speaker is saying, how can we compete with making money on the cloud? Oh, I can compete. This is our children. So I'm going to be speaking today about neonatal intensive care as a branch of critical care. I have specialised in this area, as was mentioned, since the turn of the millennium, but I also have a lot of experience broadly in critical care as well. I'm going to talk about the sheer volume of data that we have with big data. Some people say this isn't big, others say that it is big. I suppose it depends on your perspective. Talk about the clinical problems in this space, and I can actually position it with the example of the hospital in the First Nations community that we've just had, and what it's like for them when they're a child, one of those 100 children a year are born premature, and talk about the Artemis project. Unusually for a computer scientist as I am, Artemis isn't an acronym. It's named after the Greek goddess of childbearing, hence the name of that project. So, some statistics. Internationally, on average, and averages are always averages, 10% of babies are born premature. That means they're born in a 40-week gestational cycle at before 37 weeks. When they're born at that stage, their lungs are not fully developed if they're born before 37 weeks. It's the last organ to develop, or the brain may not be fully developed, or even their eyes. So the further back you go in gestation, the less development that you have. From 37 weeks, they're essentially just putting on weight. We're fortunate in Canada, the statistics are lower, in Australia even lower, but in the United States it's higher. This statistic though is on the rise. It's on the rise because women are having children until later. There's an increased incidence of diabetes and gestational diabetes. And when women leave pregnancy till later, they often have to use IVF and other techniques, which results in multiple fetuses, which would result in a high risk of having them premature. 85% of actual premature births are in Asia and Africa. And if you were to hold out your hand, men, if you want to hold out your hand, the head and torso of a premature baby at that very early stage of 17 weeks early will fit in your hand. That's how tiny they are. And they weigh only 450 grams. They can spend 3 to 4 months in the neonatal unit. And so the baby is, in under here. They have this cover to protect their eyes as their retinas continue to develop. They're on ventilator support. This one is probably about 25, 26 weeks gestation. And what is of interest to me was how they use information to help look after these babies. They're just trying to grow outside the womb. They have a natural body function that they will grow. But because they're outside the womb, they are subjected to a number of problems, and they need help to survive. They're in an intensive care unit because their vital organs need help. Their brain, their heart and their lungs all need help. But all the nursing staff and the doctors are watching for is very coarse measures of when things are going wrong. So they only watch things every 30 or 60, or they only actually annotate every 30 or 60 minutes into a paper chart. It's another diagram of all the sorts of things for the feeding, for monitoring blood oxygen saturation, for giving fluids through an IV pump, monitoring their heart through the ECG signals and any sort of warmer or incubator that they're in. This is what a neonatal unit can look like. So along the sides here, you'll see there's one here There's one here, and there's another one there. So this is a very, very busy environment. Now you try and bring parents into that to bond with their child, even though they're very small, and you're trying to have doctors and nurses work in this space. And you're trying to let the babies sleep, because ultimately when you bring them home, a lot of the time they're still sleeping because their body's spending so much time growing. So it's a very busy environment. Now let's think about information. So I said they write one number down every hour on a paper chart or in an electronic health record, which is the paper chart on a screen. And they write one number. So they write one number indicative of the heart rate for that hour. In that hour, the baby on average heart rate, and it is an average of a very varying value, on average 130 beats a minute. So in that hour, the baby's heart is beaten 7,800 times, and we record one number. They breathed more than 2,000 times, and we've taken incidental readings every second of their blood oxygen saturation. So we've got enormous amounts of data loss, as you can see. So we're in an environment where there are vast quantities of information that's largely paper-based. It's very complex interdisciplinary routine communication flows and very complex concurrent care pathways. And it's devastating when you lose a child. So this is a diagram talking about the way they currently can diagnose certain things for the baby. So we have 3 different babies on the screen, 3 different points of time. These lines here are indicative of some of the standard things like their heart rate, respiration rate, and blood oxygen level that the baby is, we're capturing information on and just displaying on the screen, and it's disappearing every second. And then at some point in time, so here, maybe 24 hours leading up to them deciding that they're suspicious that this baby might have an infection, the baby's quieter, they have abdominal distension, so a tightening in the abdomen, they may be off their food. And it's usually, even today, a well-trained nurse that can tell them that this baby's not the same baby. Because the metrics that they use to try and pick infection are so wide-ranging and usually only have a 40% true positive success rate. In this example, this baby here has been showing changes in behaviour for 24 hours, but maybe rather than being quieter, they're more active. But some of the other features may be the same. And this baby on the third one, I have, on the third one, it may be just for 6 hours rather than 24, because they may be a more or less developed baby. But what the research is showing is that if you use actually this physiology at high speed, you can start to see trends and patterns in the behaviour that are something that becomes a lot more consistent with a much higher sensitivity rate and specificity. So what we're doing in our research initially was to take information from other researchers, try and gather data ourselves, and to look at what trends and patterns we could see. But we need an infrastructure to do that. So myself as a computer scientist, my passion was to try and give them a new platform to care for patients. Now, thinking about the complex environment, even if you have an electronic health record, it doesn't cater for the nuances of neonatal intensive care and the types of information they need. This is a modelling technique we've developed as part of our my patient journey modelling or business process modelling research. You can see all the different roles that are involved, all different colours. You can see all the paper charts that they use, even in a hospital with an electronic health record, as well as the various hospital systems that they have available. So there's a lot of information. When you look at how different computing solutions are being proposed to try and analyse high-frequency data, to try and watch for certain conditions, one of the things we were able to conclude was that there was nothing that was being developed from a systemic perspective to really implement change. So retrospective analysis, what people were proposing wasn't making its way to clinical practice. The solutions weren't scalable. It's not scalable to take a laptop and go and sit it beside somebody and connect the monitor to that and gather some data for a while. That's not a scalable solution. And they were either looking at trying to train to work out patients' individual stability, or they're just watching a particular condition like infection, or they were just looking at a particular stream like a heart rate stream. So what I wanted to build was a platform. I wanted to create an environment where you could watch multiple streams, multiple patients, multiple conditions, and to be able to give that platform for clinicians to do the research and to use the platform for very new approaches to to watch for the onset of various conditions. I'd started this work in Australia in partnership with a hospital there, and I was invited to come to Canada and take up a Canada Research Chair appointment. And at that time, I presented my research at a conference in Toronto, and some researchers from IBM came up to me afterwards, and they said, we think that we have the engine for doing this work at high speed, because my research was challenged by a homegrown infrastructure to do the monitoring, and we'd only been able to get down to the second-by-second reading. And we have ECG signals at 1,000 readings a second. So we embarked on our collaboration. This is the overarching architecture. We acquire data from the medical devices. We're using a product that's now being released to market. We have been working in partnership with IBM so that they ultimately brought a streaming software platform to market. That's the base software upon which we've built our environment to analyse physiological data in real time. And we're using that as part of some clinical research studies, which we'll speak about in a minute. So we have some initial algorithms that we're testing. Some of them are based on current gold standards. Some of them are based on some of our own research to see how they perform. We also store all of the data at that high frequency. So we collect data at approximately 1,260 data points per second per patient. For those that are enrolled in our research, we use that environment, as I said, to do knowledge discovery through advanced stream-based data mining techniques that have also been part of my research. And then we can deploy algorithms into this environment to test them in traditional clinical research contexts. So we deployed this environment in August of 2009. And we used that to initially demonstrate that such a platform could keep up with the data. And it's located at the Hospital for Sick Children. Initially, it was for a maximum of 8 concurrent patients, which was a restriction of the hardware. And I'm not sure what scale you are thinking of when you think about hardware for this. So 8 patients, 1,260 data points per second, and it runs on 3 laptops. 1 laptop to acquire the data from the medical devices, 1 laptop to run in real time, and 1 laptop to handle the database that stores it. And then we poll the data back, or poll the database at Sick Kids from my university every day and pull it back to do the retrospective analysis. It's part of a clinical research study into what's listed here as nosocomial infection, but we've narrowed that to something else called late onset neonatal sepsis, which is a hospital-acquired infection for the babies. But we've also, we're now upscaling it to all the bed spaces in the NICU, but we're limited a little at the moment by the availability of the network ports, because we're trying to use wired rather than wireless connectivity. But we do have a second hospital online in a cloud computing solution, which is at Women and Infants Hospital in Providence, Rhode Island, and we started that in April of 2010. So from that time, every minute, we receive packets of data from the patients in that hospital, and the only thing installed there is the connectivity to the medical devices and pushing it out through the pipe. This is a very important aspect for me in the research, and I'll explain that in a minute when I speak about Artemis Cloud in more detail. This is an example of why we're working with IBM with this very different paradigm of computing called stream computing. It works through a very good example. Given that we had hundreds and hundreds of lines of code to try and do some very rudimentary threshold breaching observation of blood oxygen saturation falls and heart rate falls in the research that I was completing in Australia before I left. This is another study where babies at this age literally forget to breathe. Their brainstem isn't developed enough that they can have that constant firing to know that their bodies need to breathe. And if they don't breathe for more than 15 seconds, there needs to be a clinical intervention, because it can deprive the brain of oxygen, it can cause a slowing of the heart rate, and many other complications for time I won't go into. So in this example, we say, well, we want to receive the data from the medical devices. We actually need some information about their gestational age, because it's not detailed clearly on here, but we do change some of the values depending on their gestational age. And we want to watch for when, in this instance, when we have a breathing pause of 15 seconds. If, when we have that breathing pause for 15 seconds, the blood oxygen saturation also falls, and it's not just a mild event that we have a breathing pause, but this is now a moderate event because the blood oxygen saturation has fallen. And now if we have a heart rate fall as well that's impacting this, then all of a sudden we now have a severe event. Now, when you think about the current way that nursing staff look at this, if they have a severe event, they will page a resident or fellow who will come over and assist and intervene as required. When it comes to rounding time, the staff neonatologist will say what's been happening with this baby, and the nurse will say they've been having spells. And the doctor says, well, what do you mean? Oh, well, you know, I was over changing the diaper with this other baby I'm looking after on shift. And then the alarm went off. But by the time I came over, the baby had recovered. And the doctor says, well, what was the spell? Well, I'm not really sure. I was over changing the diaper on the other baby. And even though the information is trapped in the medical device, because it does have a rolling memory, they don't go back and analyse it. And since this baby's having a lot of spells, this is a problem. So this type of environment is to not only alert people in real time, but to provide that mechanism to plot the behaviours of the spells continuously. Now, the interesting thing about this example is when we translate it to the language we're using now. The diagram that you saw has a one-to-one correlation. This is single line instructions in the code. So it gives you an idea of how well it's now matching stream computing if you've ever tried to cut code in C or Java or anything else. So that's a nice example. I want to talk about rural and remote communities because people don't always choose to live in large cities. People choose to live in First Nation communities. People choose to live in other areas where it is more sparsely populated. Where I'm from in Australia, 90% of the population lives in a belt between Newcastle and Wollongong. Sorry, 10%, sorry, I don't get my statistics wrong. 90% from Brisbane to Melbourne, 10% are in where this Y is, in Sydney actually, more than that belt. So we have large areas that are vastly populated. And what we do at the moment for people who are Aboriginal or other members of the community who are born in Northern Territory, they get extracted out. The women, pregnant women, get taken away from their homes at 37 weeks to wait to give birth. And if they give birth earlier, then we have some issues with having to perform a neonatal transport. I got put in my place when I came here that I would live in a large country, but that's all right. I want to draw your attention to, most people probably here will know, Pond Inlet in Baffin Island in Ontario, because the distance from Pond Inlet, Baffin Island, down to Ottawa, where babies get extracted to if they're born premature, is the same distance down to the southernmost point of Mexico. It's a 7-hour jet ride. So at the moment in your community, you have 100 births. On average, you would say 8% of those, or 8 of those will be premature. But the reality is you probably have a higher incidence of diabetes, higher incidence where the children, where the one giving birth is younger, so you've got a high probability that you're going to have birth prematurely. When they're born premature, if they need to be ventilated, it has to be done manually. Someone is standing there hand-bagging the baby. They can't put them on a ventilator because they don't want to damage the lungs with the intubation, putting the tube in. But also, if they give them too much oxygen, they'll damage their eyes and they'll make them permanently blind. That's the type of care we're providing to the communities. They get on the telephone and they speak to a neonatologist, and it'll be a paediatrician probably or an obstetrician who is providing care. Now, whether it's First Nations community or other remote communities, that's the level of care. They can't be ventilated, they have to wait for the transport team, they're on the phone to a neonatologist. And they do a fabulous job even with that infrastructure. And I think we can do better. Because we've had this idea of remote care since 1924. So this is a model that I built initially of some research we were doing in Australia. It's called Bush Babies, after the Australian bush, where we were providing just even the raw signals of physiology, the ability to view X-ray images, and the ability to have a video stream of the baby in that remote area when the babies were being born premature or they had issues with the term baby. This image is just zoomed out. You can see my collaborating neonatologist. It was just zoomed out for privacy reasons. We tested this as well, and sending information. I was attending a conference in Hong Kong, so I was acting as the neonatologist, and we sent data through from Australia. Some computing people would say so. Well, it should work, but it's important to test these things in healthcare. So now, we were able to replace with the changes in technology. There's a lot that we didn't have to have at the hospital. We don't have the wet video camera here. But the environment that we were running in the Women and Infants Hospital, we gather the data, it goes through a secure tunnel, and I know that isn't where Providence is, but I drew the diagram before I had the permission. And we do all the analytics in real time to watch for infection. So we enrolled over 200 patients in that study. We've enrolled over 400 patients with sick kids. And we've been able to show that we have had a 100% availability rate over a 2-year period from the actual platform. 99.9% of data was received and 99% availability of the network. The one time that we lost data, that 0.1% was a network failure within the hospital that we couldn't recover from. This is just a quick diagram of the change of infrastructure for introducing the cloud around Artemis, and some work we've done on processing models and vehicle models for transport to get the data through rather than having the telephone conversation. So I've spoken about the study that we're doing with late onset neonatal sepsis. We've also been analysing data at a slower frequency to see what information we get. I have some quick charts to show you as I finish. This is looking at variability of heart rate. It's a very good indicator for infection. And so you can see it's sort of tracking around at 30, 20, 30 when we analyse this constantly. This is a baby that had surgery, went on to have infection. You can see how the black line is staying high. That's because the baby had infection. We're also looking at what we do when we introduce pain. And we've got an iPod Touch application where nurses can say their information as well. I just want to thank my collaborators as I close from all the different countries and our different funders and those in my team. Thank you.
As a parent who spent 2 months at NICU, 25 years old, I truly appreciate everything that you're doing. All big time. Questions from the audience for Caroline?
Yes.
So our team is being designed in the context of neonatal care, but could it be transferred? Because a lot of what I saw was extremely generic.
That's right.
So you could basically transfer it to other areas.
Correct. That's
ICU
right.
care, elderly care.
Yes. So I've been also working in collaboration with some research at the Columbia University in neurological ICU on complications after subarachnoid hemorrhage, which is a hemorrhage of the brain. It's the same sort of principles. We adjust some of the algorithms and some of the thresholds, but watching for infection, it's still that reduced heart rate variability. And it can even go outside, albeit probably with slower frequency monitoring, but monitoring ambulatory patients with cancer, leukemia, to watch for a whole lot of conditions. It's a platform. Yes.
Can you touch a little bit on the scalability and what the opportunities are and where you see the threats?
So first of all, in terms of opportunity, we've got so many medical devices that we're not connecting to and doing more with. The numbers just flash up on screens all around the place. So my goal and what I'm working now in partnership, we're establishing a social enterprise. That is the social enterprise to manage the collection and also the use of this information, not just for the real-time use, but also as a research platform. So in Ontario, we're upscaling this now and starting to look at how we can build this, take this to the next level of cloud computing.